I think before we talk about these questions, we have to discuss what drug refractory epilepsy is. So you are probably aware that the prognosis of epilepsy in general is quite good. So around 65% of all patients with epilepsy do become seizure-free sooner or later. Well, on the other hand, that means around 35% of patients cannot be treated satisfactorily with anti-seizure medications. And so if you have done 2 drug trials in epilepsy in a given patient, then you know this is a refractory epilepsy. Of course, the drugs have to be chosen adequately, and you need a sufficiently long observational period and sufficiently high doses and so on. But after that, after 2 failed trials, it's a drug refractory epilepsy. What are the current treatment options for drug refractory epilepsy? Well, on first sight, it's the same drugs that you can use also in beginning epilepsy. The modern way of epilepsy treatment is to try and avoid enzyme-inducing anti-seizure medications, and it should be ASMs, which is the abbreviation for that, that do not cause cognitive side effects, if any possible. Well, talking about focal epilepsy, the drug of first choice currently is lamotrigine, at least after the SANAD-2 trial, which has shown its superiority over the other available treatment options. Levetiracetam is also a drug which is not associated with any relevant enzyme-inducing or enzyme-inhibiting properties, not associated with cognitive side effects, sometimes associated with behavioral adverse events. In first instance, you try to treat a patient with a monotherapy, i.e. with one anti-seizure medication on its own without combining with other ones. But usually patients with drug refractory epilepsy are on a combination of 2 or even 3 anti-seizure medications. You should definitely aim at giving not more than 3 ASMs because, well, the risk of side effects will increase. So, yes, talking about combination therapy, well, there is still much to learn about the so-called rational polytherapy. We try to use, in that case, ASMs, which have complementary mechanisms of action. So just to give you an example, many ASMs are sodium channel blocking agents, and you normally do not combine 2 or more sodium channel blocking agents, but you may have a sodium channel blocking ASM combining with another mode of action. And of course, you have to consider pharmacokinetic interactions. So, for instance, the combination of lamotrigine and valproic acid is a very good one in terms of efficacy, because valproic acid will increase by its enzyme-inhibiting properties the serum concentrations of lamotrigine, which is very desirable in many patients. And maybe there are pharmacodynamic interactions between these drugs as well, leading to a synergistic effect. Having said that, there are, of course, restrictions against the use of valproic acid in women of childbearing potential.